We are coming to study this particular the joint of the upper limb. I'll be just taking care of this shoulder joint, which includes this other joint as well. We call them as pectoral girdle, which is a circular or uh, near circular network of joints, which is related to this particular upper extremity and joining this upper extremity to the main body trunk. So, we call this particular pectoral girdle which is joining this upper limb with this trunk, which is the body we have, and pelvic girdle we talk that the lower limb which is joining this particular with the body with this region. So, this hip bone region we call them as pelvic girdle, and the shoulder region we call them as pectoral girdle. So, that is what we are going to study today. So, first half of this we will be going to talk about these joints and related relevant relevance on the pectoral girdle, and then we move to, after a break we move to the clinical problems related to the shoulder joint on that. So, we have this particular topics to cover this pectoral girdle that we are going to cover, components of it and joints, what are the bones which is forming, what are the binding factors which are holding this particular joint in place, what are the movements that is relevant to that particular joint, to this upper limb, etc., etc. And our main emphasis will be on this glenohumeral or part of the shoulder joint of this pectoral girdle region, and their clinical problem related to it, which is very frequently coming to us as a clinical questions. And other joints which is there like elbow joint or wrist joint, which will be taken subsequently in some other classes as well. So, this is what we are going to talk today is pectoral girdle. So, we have to understand this is a near circular entity which is present in this particular shoulder region. So, this one half and other half, that means right half and the left half together, they are making a kind of like a continuous lines over here, and on the back side is a little bit incomplete because we have a bone on the back side, we call them as like a scapula, which is not directly attached to this particular vertebral bone on the posterior side in means of joints. So, in the back side of this particular pectoral or shoulder girdle is incomplete, but frontally it is more or less complete. This clavicle meets with this particular sternum manubrium part, and this particular clavicle joining with this particular bone which is known as the acromion process of the scapula, and this particular bone which is known as this humerus joining with this particular scapula, holding this particular entire thing together, makes this particular pectoral girdle region, which is a bony ring, but not that greatly complete. Whereas, in case of the pelvic girdle, which is like grossly more complete in terms of bony architecture is concerned. Now, in this particular shoulder region, if you are going to talk about any movement, largely this movement is happening over this region. We call them as a glenohumeral joint. That means a part of the shoulder joint with this humerus with the glenoid cavity of this scapula, we call them as glenohumeral joint. So, this particular joint principally moves. Along with this particular movement, this particular clavicle also addresses some sort of movement. So, this particular clavicle have got like a movement which is present in here, and this clavicle is joining with over this sternum on this medial side and this acromial process on this lateral side. So, we forming two kind of joints, sternoclavicular joint and acromioclavicular joint. So, this movement of this glenohumeral joint and these two joints of this clavicle over manubrium and over the acromial process also adds up together as a movement of this pectoral girdle. Now, our part of the job is there to single out these two joints or these three joints and learn detail of it and the clinical problems which are related to it. So, that is what we are going to learn in the next 2 hours or so. So, this is what we are going to deal with. So, whenever we are going to talk about this particular joints in the upper limb, there are several joints which are present. As you can see, joining with this humerus with the scapula, clavicle with these two joints, bones, humerus joining is the radius and ulna, and this radius and ulna forming this joint to the carpal bones, and this bones which are present in this particular hand or our wrist as well. So, these are number of joints which are present. Our prime concern will be addressing the joint over this pectoral region for the day over here. So, these are the different joints that we are going to be encountering in subsequent time with the course movement. And we are going to talk about the sternoclavicular joint, acromioclavicular joint, the two joints that is related to this particular clavicle, and the glenohumeral joint, that means this humerus uniting with the scapula at the glenoid labrum or glenoid cavity. Now, taking this particular first joint at a time. So, whenever you are going to address this particular joint, we are going to address couple of points whenever you are stating it, like what this joint is type about, like synovial or non-synovial. So, if it is synovial, it should have a synovial membrane inside, it should have a fluid inside. To lubricate that, we call them as synovial fluid. That is basic architecture of any synovial joint. Covering this synovial membrane, we have a capsule. We call them as capsule of the joint or capsular ligament. That is also universal. These two things are universal to it. Now, other than this, we have some additional ligaments which is different in each of the different joints which are present, and they have a different name and they have a different directions. That is different for each and every one. That is what we have to focus little bit whenever we are addressing an individual ligament which is holding this particular joint. So, we call them as ligaments which is holding. Coming to this particular bones which are framing of this joint, like clavicle joining with this manubrium. That means, what are the two bones or parts of the two bones making the joint, that what we have to keep in mind. Next, movements. So, what are the movements that is present across that particular joint? That means flexion, extension, rotations, medial rotation, lateral rotations, forward movement, backward movement, rotation forward, rotation backwards, or a circular circumduction movement. So, these are the different types of movement that is going to be encountering whenever we are coming across. So, that movement we have to know. If you know the movement, if that particular joint is very highly rated important joint, we have to know that what are the muscles that is making those kind of movements, and putting a logic, like we cannot memorize all these particular muscles involving that particular joint movement, but at least we should put a rational mind towards memorizing the muscles which are moving to it. And if you have a muscles related to that particular joint movement, there must have some nerves which are moving the muscles. So, those nerves which are moving that particular muscles will be adjuvantly supplying that particular joint. Now, joint has a position sense. We call them as joint position sense. That means, even eyes closed, you can see that, or you can feel that our joints are normally placed or not. Is it disrupted or it is in normal position or not? We call them as joint position sense. That particular sense is subconscious. Even though you are not paying address to that particular thing, whether my shoulder joint is right place or not, you know that it is there. So, that particular subconscious feeling of a joint in normal position, we call them as joint position sense. That particular joint position sense is contributed by the nerves which is nearby, and that particular nerve continuously sending the signal to the brain that it is there in normal position. Now, if it is not in normal position, say for example, I have a position error of this shoulder joint or any other joint, that particular signal will be coming to your brain that my joint is hurting, my joint is not going good, like that. So, that particular joint position sense is picked up by the nerves which is there, which is giving the right sense that joint is normal in position, right. Other thing is that there is a vibration sense across this particular joint. That means, whenever we are moving this particular joint, there is a vibration or friction going on. That particular vibrations also picked up by these particular nerves. We call them as proprioceptions. That means, a sense of picking up this particular friction and vibrations. That too also picked up by the nerves which is nearby nerves, muscles which are supplying to it, the nerves, and this particular nerves which is running across sends it to it, they pick up and send the signal to the brain. That is why we sense this particular joint position sense and the vibration sense along with the movements of it. So, in physiology, they will talk about that particular thing, about this particular joints or positions of the leg or positions of the hand. If we do not have that particular feeling of that particular positions, the nerves remains to send the informations. Say for example, after amputation, the person feels that the limb is there. So, that kind of phenomenon we call them as phantom limb phenomenon. In physiology, they will narrate about that particular phenomenon, phantom limb or what kind of things, and they will be addressing that. So, that particular thing comes in mind about joint position and this movement related to the particular joint and the nerve supply which is related to it. Now, this is like a free trace of this thing that we are going to learn, that we are going to do, and we are landing up in the joint actually, whatever we are going to study. So, we pick up this particular clavicle, and this is clavicle which is placed around horizontal plane, and this particular horizontal plane placed clavicle is extending between this midline bone, which is the sternum, and going on the back side little bit on the lateral extremity as the acromial process. So, between this particular clavicle holds two joints, one joint between this particular sternum and clavicle, we call them a sternoclavicular joint. Now, following the rule that what we are going to see, that what type of joint it is. So, it is a synovial or non-synovial, that is a basic thing that you have to ask yourself. This is a synovial membrane having this joint present to it. So, it is a synovial joint. And what subtype of the synovial joint, if you can remember, that is good. If you cannot remember what subtype of the synovial joint it is, just let go. So, this particular joint we call them a saddle type of synovial joint. So, this particular saddle type of synovial joint which is present in the sternoclavicular joint existing over here, an articular surface, that means what particular bone surface comes here to forms this joint. So, we can see that this particular clavicle, this is which end of the clavicle? Medial end. So, medial end of the clavicle joining with the sternum. Which part of the sternum? Manubrium part of the sternum. So, there are articular surface is easy, like manubrium and clavicle, you have to narrate that which part of it is making this particular joint. Now, after that, this particular joint, if it is synovial cavity, it should have a synovial type of joint, which should have a synovial membrane lining things. So, it is lined by the synovial membrane and it should hold a cavity to it. We call them a synovial joint cavity which is present. Now, if that particular joint cavity having any kind of special features that we have to mention. In this particular area, this particular synovial joint which is present between the manubrium and this clavicle, having a synovial cavity which is split into medial and lateral half by a placement of a cartilage. So, it is splitting this particular joint inside into two halves, medial half and lateral half. If you pay attention to close to this particular picture, this part we have this particular everything inside, and this is the covering which is capsules are removed. So, this cartilage which is existing between the manubrium, splitting this into this particular cavity into two half, one half, another half. This is the medial half, this is the lateral half. So, this is there. So, but is it significant to us for clinical reason? No. If you do not remember this medial half, lateral half split of these things, nothing is going to be troublesome for us. So, we can drop it like if you do not want to catch it. Alright. So, what we have to carry out here, it is a synovial type of joint. If you can remember what type of synovial joint, it is a saddle type. If you cannot remember, just remember the synovial joint, just do not let the synovial thing go from your mind. Clear? So, to catch this particular saddle type, just do not let go this synovial word. The synovial word is more important than the saddle type. Clear? So, these things you should be keeping in mind. This is synovial joint, that is it. I do not remember any further and no harm in it. Now, if you have the synovial joint which is present, synovial joint has a basic architecture. Inside to it, it has a cavity, and that particular cavity is lined by a thin living membrane. That membrane we call them as synovial membrane, and this particular cavity holds a fluid inside, we call them as synovial fluid. That is the basic architecture of these things, right? Now, outside to this particular thing which is present in here is covered by another membrane, we call them as capsule. Capsule is tough, like fascia that we have seen. When I was cutting the fascia, it was thick, tough. So, we call this capsule or capsular ligament, which is holding this, which you are seeing here present in here. So, capsular ligament is there, which is more tough in nature than that of synovial membrane, which is covering this particular synovial membrane from outside, and this have got a lot of fibers on it, like collagen fibers over there. Okay, clear? Now, I throw some question. So, if you are approaching to this particular joint, say for example, cutting through the skin and going deep to reach to this joint. So, if you cut the skin, you cut it, then you cut the fascia, you cut it, then you get this particular joint. So, what covering you will get first? Capsular ligament or synovial ligament? Good. Now, this is how it looks like, this particular capsule which is present on it. Now, surrounding the capsule, it has some other ligament which is reinforcing the capsule or this particular joint. We call them as specific ligaments that is present on this capsular ligament, synovial membrane, or these things are present in all the joints. This is what which is special to this particular joint. The ligaments which is present is capsular ligament that we have known of. Then another ligament we call them a sternoclavicular ligament, that means running from sternum and going to the clavicle. Sternoclavicular ligament. The joint is about sternoclavicular joint. Now this particular ligament have got two filaments, anterior and posterior. We call them as anterior sternoclavicular ligament and posterior sternoclavicular ligaments, right? Then in between these clavicles we have this particular ligament existing from right side to left side. We call them as interclavicular ligaments. And there is a fourth or another ligament which is weird present in here between these ribs to this particular clavicle. We call them as Costoclavicular ligament. So this tiny slip from this rib one going to this particular clavicle, anchoring over here, reinforcing this particular capsule or capsular joint over here, joining this particular thing together. So we call them as costoclavicular ligament. So capsular ligament, outside to that we have the ligaments which is binding it, anterior and posterior sternoclavicular, interclavicular, and the costoclavicular ligament. This is what we have to memorize. Little bit words about this which is there. So remember this word like sternoclavicular ligament by the name of the joint itself, anterior and posterior slips. This interclavicular, if you remember, fine. If you do not, just fine. Costoclavicular, if you remember, fine. If not, let go. What can we do? But at least you remember the synovial membrane, synovial joint, capsule, and these two of them. Clear? Now coming to the next part of these things, movements. So this particular joint is capable of having movement. Any synovial joint moves. Any synovial joint has a feature which is having a mobility. It's mobile. No matter how it is, like it may be just like a 5 degree to 150 degree, but it has a mobility. So mobility is a hallmark for any synovial kind of joints. So this particular joint also have movements. The movements are of different planes. It can move anteriorly, it can move posteriorly. We call them as protraction, it called retraction. It can move up and move down. So moving upwards and moving downwards. It can glide or it can just like rotate. It can rotate anteriorly, rotate backwards, depending on movements of the shoulder joint, flexion, extension, whatever the things we are doing. This particular joint also makes a movement. So depending on different axes or different plates. Clear? So there are movements which is present in here. What movements is present is elevation and depression on the down, up and down. Then it is moving forward and moving back. So depending on flexion and extension of the shoulder joint, it is moving up and anteriorly or moving backwardly. So we call them as protraction and retraction. Now protraction and retraction is again very prominent in case of this joint, the jaw joint. You see that you can move the jaw forward. This is known as protraction, and again after protraction you can put it back. That is known as retraction. That means you are protracting it and then putting it back. So protraction and retraction is a forward and backward movement which is present there. Rotation, which is forward rotations and backward rotation depending on the shoulder movement. If you are moving this particular shoulder joint forward and backwards, this particular joint can move forward and backward, and the axis changes, it becomes this particular horizontal axis. So it is basically making a roll over here. So these are the three different things that is making this particular joint move, and this particular joint is quite movable or quite mobile joint. So these are the things that you have to keep in mind: type of joint, articular facets which are making here, and then we have to know these particular ligaments, and then the movements of it, possible like anterior posterior movement, upward downward movement, and this rotation. If you can remember, fine. If don't, just try to improvise. Other type of joint, which is second one. So again the same logic, same way there. So first thing is that whether it is synovial or non-synovial, it is synovial type joint. And if you remember the type of the synovial joint which is good, or else just don't let the synovial thing go off your mind. Clear? So we restrict it is a synovial type of joint, and subtype we just do not bother. Alright. Now what type of joint it is? Synovial joint. What are the articular part which is making this particular joint? Clavicle. Which part of the clavicle? Lateral part of the clavicle. And uniting with which bone? Acromion bone. And this particular joint we call them as Acromioclavicular joint. So this is synovial joint, and this particular synovial joint is capable of movement or no? Movement. So it will be having some sort of movement which is present to it. And this particular joint have got what are the features like this? articular facets is there, and if you have this particular joint present, you should have some ligaments related to it. So, what are the ligaments? The ligament which is always present to this particular joint? Capsular ligament. So, it also have capsular ligament. So, side it has capsular ligament. Inside to the capsule, what it should have? Synovial membrane. Inside the synovial membrane, it should have a cavity. That cavity should have synovial fluid. So, coming back to the capsular ligament, which is present over here. What special ligament it could have in this particular ligament, that we have to emphasize. Clear? Now, so this particular region have got number of ligament which is important, and it is more important than that of midline joint that you have studied. So, this region you have to pay attention, these ligaments you have to keep in mind. So, this is what we already have known, articular facet and synovial joint. Now, coming to this particular ligaments and the movements, which is important for us. Movements of this joint is less compared to the front joint that you have learned, but the ligaments are more important in here. The ligaments which is present in here is capsular ligament that we have known over here. Other ligament which is present goes by the name of the joint, that means acromioclavicular ligament. That is the main ligament of this. So, which is holding this particular joint together. So, acromioclavicular ligament is the ligament running between the acromion process to the clavicle holding this. So, acromioclavicular ligament by the name of the joint we can figure out. Now, more important to it, it has another ligament which is coming between the coracoid process to this particular clavicle. So, this is a coracoid process, bird's beak, remember, which is pointy. So, this coracoid process to this particular clavicle, we have a ligament, we call them as Coracoclavicular ligament, Coracoclavicular ligament, and another ligament which is running between the coracoid process to acromion, we call them as Coracoacromial ligament. These are the two special ligaments this thing has, and they are more clinically relevant for us because we will land up in here. So, we have a capsular ligament which is present in here, then we have a special ligament which is present in here by the name of this joint itself, acromioclavicular ligament which is present. But we will emphasize on something else other than this, which is running between the coracoid process to this particular clavicle, Coracoclavicular ligament, and this coracoid process to the acromion we call them as Coracoacromial ligament. These are the two special ligaments. Out of these two, we will put more focus on the Coracoclavicular ligament, CCL. Now, why so? This Coracoclavicular ligament have got two parts. This ligament which is running between the coracoid process to this one have got two parts on it, like two subparts. Now, I do not want to complicate this with the names of this particular thing, but remember this have got two subparts which is running between the coracoid process to this particular clavicle, right? Now, importance of this particular Coracoclavicular ligament is that this particular ligament transmits or bears the weight from upper limb to this particular shoulder region or this trunk. You follow what I am saying? This hand has a weight. This hand also have a 2.5 kilo ka haath. कहते हैं ना वो क्या कहते हैं? Sunny Devil. So we have this particular hand weight on it. Now this particular hand weight need to be transmitted to my trunk. Or else, if you are not holding this particular thing enough, our hand will be dropping off. Or every time you have to pull it up and then what? Drop and pull it up and drop. So this ligament, which is doing this job of transmissions of weight from the hand to this particular trunk. Get it what I am saying? It is transmitting the weight through it. How it is doing? Is geometry, physics. I don't know anything about it. It is doing it. I don't bother. It is doing it. Somebody said it. I believe it. If you want to say that like how it is doing, geometrically possible, show me the vector analysis, angles and everything. I say okay, let me go back to my like 7th standard class and come back after reading that 7 to 12 years, then I will maybe explain it to you. I don't remember anything about those things. But thing is that this ligament transmits the weight from here to here, and I believe it. Why I believe it? Because if this ligament is knocked out, that means if this ligament is broken, my hand will be dropping off. We call this as a shoulder separation, and every time I have to pull it up and do the work, which I do not want to do. So I believe it. So this ligament, we call them as Coracoclavicular ligament, is the one which is transmitting the greater part of the weight of the upper limb to the clavicle. And here lies the clinical question. Now, having this particular thing which is quite strong, the ligaments are quite strong. You can understand this is taking a lot of weight, but even though this is weak as a joint. So, this particular joint is weak. Why I am saying this is a weak joint? If I fall right now, if I fall like this, if I hit by any chance over here, this joint will be dislocated. Which joint? The acromioclavicular joint. This joint which is present in the sternum region, it is stable. This joint will be snapped. Now, what is binding this particular joint to hold this in position? Ligaments. What are the ligaments which is holding it? Acromioclavicular ligament and Coracoclavicular ligament and Coracoacromial ligament. Out of that, one is very important for us. Which one? CCL, Coracoclavicular ligament. Why? That transmits weight. And what happens if it quits the job? It falls. So that happens. Then we call them as separation of shoulder. This is what it happens. So I fall on the shoulder, snap this joint, and this particular thing is disrupted. So see that two clinical thing, clear your mind over here. So picture 1 and picture 2, they are not similar, okay. Just drop everything, try to see this. This particular thing is there, you see that this particular joint is disrupted over the red. Clear? That means joint is broken. Capsular ligament, synovial ligament and the Coracoclavicular ligament, acromioclavicular ligament is snapped. But these two are present between this coracoid process to this particular clavicle there. So, this particular coracoclavicular ligament is there and this particular coracoacromial is also there. So, what happens to this person? They have a dislocation without dropping of shoulder. Clear? Now, look at this next picture over here. What happens here? This particular thing is snapped. Along with this, weight bearing ligament is lost. Which ligament is lost? Weight bearing one. Which one is bearing weight? That one is snapped. You see that? It is broken. Then we have this particular shoulder dropping. So, this acromio AC dislocation, that acromioclavicular dislocation is often called shoulder separation or shoulder separation disease or dislocation of acromioclavicular joint is severe in both of the cases of this region where this acromioclavicular ligament and this coracoclavicular ligaments are torn, and as a result of that this particular shoulder drops and it is falling on in weight. So, every time these things have, you have to just like jack it up and do the work. So, you understand what is this? What is shoulder separation? So, the ligament which is bearing the weight is lost. So, if I come tomorrow like this, will you be able to identify that what problem I am going through with the shoulder? I say that this is, I am dropping like, yeah, tell me. Then understand what's going on. And if I coming with the pain with this and still I am holding it and holding it, that means I still have this ligament there, some weight transmission is there. Understand the difference? Okay, so how long you are sleeping at night? 2 hours, 3 hours, 4 hours or less? 4 hours? Not even 4 hours, 2 hours. Feeling sleepy? Yeah, you should be. Alright, okay. You need a break. Any stretch break, air break, entertainment break. Need a break? You can take it more. Sure. No separation from class, right? You will be still here, not in just like a different world, right? Yes. So that movie, right? What does that movie? The person sleeps and goes to another world in a machine. Inception? Inception. Goes to another world works there. Okay. So, after this we move into the main chapter. Glenohumeral joint, that means shoulder joint that we refer actually. Glenoid process or glenoid cavity with the humerus. Humerus is a what type of bone? And it has what parts? Upper end, shaft, lower end. Upper end having head and the tubercle, right, and the head part of the humerus joining with this glenoid cavity and making this joint. That is why you call them as good. What type of joint it is? Synovial. What subtype? Ball and socket. Great. So, synovial. What do you mean by synovial? Membrane, cavity, fluid, mobility. That is it. So, what are the articular part? We know. What are the type of joint? We know. What are the subtype even? We know. Right. So, major job is done. Type of joint, we know. Articular surface, we know. And then talking about little bit about glenoid labrum. Sometimes it comes as a short note. Now, what is glenoid labrum? It is a kind of cushion. What kind of cushion? It is a fibrous cushion or fibrocartilaginous cushion, which is fibrocartilaginous cushion. That means this is just like a ring. You see this particular picture? Sorry. So, this particular thing is that glenoid labrum. It is a kind of circular disc which is having a rim, just like a ring. So, this particular labrum is made of what? Cartilage. What kind of cartilage? Fibrocartilage. What are the different types of cartilage you know? We have the hyaline cartilage, we have a fibrocartilage and we have a elastic cartilage. This cartilage is fibrocartilage. That means it has a capacity to take some shocks, right. So, fibrocartilaginous disc. What it is doing is fitted to the margins of this glenoid cavity. That means margin means not covering the whole thing, it is present in the margin. This is having a central thing which is cavity, which is fitting into it. What the thing it is doing? It is putting this cavity of this glenoid space or glenoid cavity from shallow to deep. That means this glenoid, if you look at it, it is shallow. That means it must not have depth. So, it is adding a depth to it, this ring. That means it becomes shallow to deep. So, that on this cup, this head can fit and it can become little bit substance rich. Whenever you are making a movement, this things frictionless runs for a time and gets this particular joint little bit stabilized. So, this is about glenoid labrum. So, this few words about glenoid labrum is good enough to narrate it as a short note, 2-mark short note with a schematic diagram. So, what is a glenoid labrum? Fibrocartilage ring. Where it is fitted? What it is doing? Providing depth to the cavity. Which cavity? Glenoid cavity. And what joint it is benefited out of this? Glenohumeral joint, right? Good. So, this particular thing you have to know about. So, where it is attached and what it is doing, deepening this joint cavity. Now, this particular joint has got movements that we are going to refer. Now, other than this particular joints have got some ligaments which is associated with just like any other joints. What are the ligaments that is present that we know? Capsular ligament. Under this capsular, over this capsular ligament we have the synovial membrane, right? No, inside, okay, my bad. Okay, inside to it, if you cut this, then only we can see this. Okay, good. So, this capsular ligament is this one which is wrapping. Then we have this special ligaments which is present in this particular joint. So, this ligament which is present in here, which is going to make this particular joint special, like Coracohumeral ligament. That means coracoid process to the humerus, glenoid to humerus, glenohumeral, transverse humeral. These are the three ligaments which is binding it, and they are not very strong, not very useful, not very powerful ligaments that they are present. But though they are there, we have to remember the names. Clear? So, these names are there between this particular coracoid process to humerus, glenoid to this humerus and this transverse humeral ligament, they are making this special kind of ligament that is present in it. Besides this, capsular ligament which is present in it. So, these are the three ligaments that is related to this particular thing, which is adding up to the stability of the joint. This particular joint is very mobile joint. You can see that we can do any range of movement, right. So, this is having too much mobile joint. So, this joint need to be stable, but we do not have a stability on this joint. The stability of this joint is compromised because it wanders and moves too fast. So, we have some stabilizing factor to hold this joint in place so that it is not slipping out. So, this slippage is prevented by these ligaments which is present in here. Addition to it, we have a special feature which is also reinforcing that. What is that? We call this as a musculotendinous covering or musculotendinous sleeve which is holding this. So, number of muscles they are present surrounding this joint, and those muscle tendons or these particular flattened tendons, they form a cuff or a belt like structure, just like belt like structure around this particular joint and giving a stability or support to this joint. That particular cuff like structure which is holding, surrounding outside to this thing, we call them as rotator cuff, which is rotating the joint but giving some stability. So, that rotator cuff is present around this particular joint. What are the muscles that is present around the joint? You can see that Supraspinatus, Infraspinatus, Teres minor, Subscapularis. They are around this particular joint and they are working on these joints. Their tendon ending on upper end of the humerus. You remember that the greater tuberosity or tubercle and lesser tubercle. There these particular ligaments are attached from this scapula to there, and they are going from these two spots and limited to it, and their tendons making a continuous joining with each other, they are making a continuous sleeve. That sleeve surrounding this capsule or capsular ligament or joint ligament, they are giving a reinforcement to this joint. So, that part we call them as rotator cuff. What is a rotator cuff? It is a musculotendinous cuff formed by tendons of supraspinatus, infraspinatus, teres minor, and from medial side subscapularis. They are strengthening the shoulder joint. How? By making a continuous sleeves to support these things. Clear? So, they are kind of giving a support to this particular joint and holding this in place. Now, these are the one thing that is helping this stabilizing it. We will come to rotator cuff after that when clinical problems there. Then we have this particular partitions over there, we have the bones there projected over here, acromial process and the coracoid process. They are arching on top. So, together we call them as coracoacromial arch. So, these bones are present over there. So, this particular shoulder joint, upper part of this is somehow is guarded from above. So, if anything falls from above, it is not falling on this joint itself, it is falling on this particular bones which is acromial process and coracoid process. So, we call them as coracoacromial joint. So, these four factors basically holding this or this particular joint to give it stability. What are the four factors? Is that capsular ligament, surrounding ligaments that we mentioned over here, rotator cuff which is what we know, and this fourth factor is this coracoacromial arch which is holding this. Addition to that, the cavity of this particular joint is deepened by this labrum, so that this cavity of this joint becomes little deep, so that it gives some kind of mobile stability whenever we are making a movement. So, these are the factors which is stabilizing the joint even though this joint is grossly unstable. Clear? So, the question comes to you like, state the factors which is stabilizing the joint. So, you have to say that A, B, C, D, E and how they are making, just like one liner, two liner words with pictures on it, schematic. Clear? Now, next question comes, narrate little more or describe this rotator cuff with 3 marks question or 4 mark question. Then you have to narrate the things specially about this particular rotator cuff, addition to this particular stabilizing factors. Clear? Good. So, Other than this, we have some kind of cushions present in this particular joint. What do you mean by the cushions? We call them as bursa. They are kind of like a packing material, which is like pillows, small pillows. Just like the back cushions when you sit in a sofa, it has small cushions, something like that. So in this joint as well, they have some additional cushions to limit this particular frictions. These cushions are filled with fluid or air. We call them as bursa, B-U-R-S-A, bursa. The two of them are important in here, which you have to know the names before we take a break. So there are two bursas or the pillows are there. What are these pillows which is present off here? One pillow is present below here. We have this bone. What this bone is there? Acromial process. So this acromial process and this is coracoid process. So this particular cushion which is present under this acromion, we call them as subacromial bursa. Where this acromial bursa is present, you see that above we have this bone. What bone? Acromial process. So it is present between the acromial process above and below we have this particular muscle tendon running, which is making a floor of it. What muscle present in coming from here? Supraspinatus. So between the supraspinatus tendon and this acromial process above, this cushion or pillow is placed. So what do you know by the name of this? Subacromial bursa. Where it is placed? In the shoulder joint region. Where exactly it is present in the shoulder joint? Between the acromial process above and the floor, which is supraspinatus tendon, which is going to make this particular rotator cuff. That means it is outside the rotator cuff. Clear or not? So this is one bursa that is present between this acromial arch and the supraspinatus tendon. What is functions of this bursa is that reduce friction between supraspinatus tendon and this acromial process and over here. So this particular joint, whenever it is making rotator cuff, whenever it is rotating, this is limiting the friction. That means putting some friction place pillow coverage there. This is one. Another one which is present under to it. We call this particular thing as under subscapularis. We have a muscle here which is coming from the scapula, is subscapularis. So this subscapula, between this particular neck of this particular scapula and this particular subscapularis muscle, there is another bursa, another pillow. We call them a subscapular bursa, which is related to the neck of the scapula. Out of these two, subscapular bursa and subacromial bursa, we have to know that both of the names and emphasize on subacromial bursa, because clinical problem will be fixed on acromial or subacromial or subdental bursitis or inflammations. So you have to know these two cushions or pillars are there, subacromial and subscapular. Out of this subacromial, we have to emphasize. We are going through the architecture of the joint, which is nearly 90% is over. Now we are going to talk about the clinical things and how these clinical problems are going to come related to the joints that we are going to emphasize on. So it will be like maximum 30 minutes. It's not going to much long. So I'll be brief and case. So coming back to this particular bursa, before we just finish, there are two cushions, kind of patches which is there. Bursa, anywhere it is the same. It is a kind of cushion pack or cushion bag. It may be filled with fluid or may be filled up with air. So it is air filled or fluid filled pouch which is present at the friction side of a joint, saving this particular tendons which are present or muscles which are present around the joint while they are making this movement, so that it do not get burned out with the bones friction whenever we are making a rigorous kind of movement. It is present around this particular most important weight bearing joints like knee joints. Some of the bursas are present in the hip joint as well. The joints or bursas are present in the shoulder joint. They are very weight taking joints and as well as they are load taking joints which are present. So this particular bursas out here is like here to mention over here is the subacromial bursa that we emphasize out of these two. And subacromial bursa is itself is a short note, and again 2 marks 3 mark short notes will be there. Subacromial bursa, what is it? So you have to say about it is a fluid filled or air filled pouch, and this particular fluid filled air filled pouch is present around the shoulder joint, and exact location is between the acromial bone above and supraspinatus tendon below. What is the function of it? To reduce the friction of the tendons of the rotator cuff, so that this particular tendon when it is working, this particular bone above this acromial bone do not get too much friction whenever this supraspinatus muscle is working. So, it is present outside the rotator cuff, which is kind of additional thing. Another bursa present between this particular neck of the scapula and this particular region, we have this muscle which is coming off here is subscapularis. So, subscapularis muscle is separated from this particular neck of the scapula whenever this particular things comes to in contact, so that this gives another cushions out here. So, this is about these particular two bursas. Now, coming to the movements of this particular shoulder joint that we have to keep in mind related to the shoulder joint. So, shoulder joint is the highest mobile joint that we have so far. So, this shoulder joint has a wide range of movement. So, it has a movement we call them as flexion and extension. It has a movement we call them as medial rotation and lateral rotations. It has a movement we call them as abduction and adduction. It has a movement which is clumping and surrounding this, we call them as circumduction. So, it has a wide range of movement, and each range of movement is very versatile. That is why we can just like move the hand like anywhere, any directions. So, we have to follow these particular movements of this particular shoulder joint. So, we have to be in anatomical positions like this, and in this particular positions we have to exercise this movement. So, first we talk about this particular movement which is moving like this, we call them as flexion movement. This movement of the shoulder joint is flexion of the shoulder joint, and if we move it back, it would be extension. So, flexion, extension. Then if I move it in the right angle, this movement we call them as abduction, and if I close it, we call them as ADD, A double deduction, abduction, A double deduction. Now, if I fold it like this and then if I move it, it is a rotation. It is outside rotation, we call them as lateral rotation, and opposite to it, if I do it, medial rotation. So, lateral rotation, medial rotation, which are pressing together. Sum of all. So, these are the movements that is present in here principally over there. So, we have to know the muscles which are related to this particular movement, and out of these particular movements, one movement is very important. I will tell about last at the end of this particular movement muscle involved in it. So, talking about this particular movement which is flexion. So, it is done by two muscles. One is this pec major and one muscle above which is deltoid. So, deltoid have got anterior fiber, middle fiber and posterior fiber. So, anterior part of the deltoid and this pec major is doing it. So, flexion, pec major, deltoid. Extension, just like pec, we have a muscle in the back, we call them as lat, latissimus. So, this particular thing is pulled by lat, and again this one deltoid. So, deltoid and this lat is doing extension, and pec and deltoid is doing. Now, coming to this rotation, lateral rotation and medial rotation, right. So, these two rotations, lateral rotations and the medial rotations, are done by the two of these, which we call them as medial rotation at the first. So, medially if you are rotating this, the muscle will be coming common here is deltoid. So, deltoid is doing medial rotation and lateral rotation at the same time, two different fibers are working. So, deltoid is constant for flexion, extension, medial rotation and lateral rotation. That's a one thing done. So, deltoid is a muscle can do any shoulder joint movement except this A double deduction. So, deltoid is doing all the movement except one. What is that? A double deduction. It is not doing A double deduction, but rest of these things is any movement, name any shoulder joint movement, you place it deltoid. Then you have to add it accordingly. So, we are talking about this particular medial rotation, you are making this medially rotate, that means medial muscles will be there helping us, pectoralis major, which is moving these things, anterior fiber of deltoid, and medial rotations. Along with that, if you are just doing it, this latissimus dorsi is also, teres major is also helping. Coming to this lateral rotation, again deltoid, and it is assisted by teres minor and infraspinatus. These are the two muscles which is maybe making this particular lateral rotations or moving these things sideways in terms of infraspinatus and the Teres minor. So these are the 4 movements that is present over this particular actions over there, which is demanding muscle actions, flexion, extension, medial rotations and the lateral rotations, and you can place deltoid in every one of them. Now coming to this particular side movement, abduction and a double deduction. A double deduction, we take it together first. In a double deduction, which you just like doing it, like we are just like closing this, like bringing it closer, is done by this pec major and latissimus dorsi. So these 2 muscles, anterior and posterior, they are bringing it closer. So a double deduction is done by this particular pec major and the latissimus dorsi. Now last we are left with this side movements, which is taking it away. We call them as abduction. The abduction needs introductions. Abduction have got 3 phases: initiation phase, then middle phase and final phase. So there are 3 phases of this abduction: 0 to 15 degree, 15 to 90, 90 to 180 and beyond. This 3 way we can split these actions. So this lateral movement, first 15 degree is principally done by the muscle which is known as supraspinatus, assisted by deltoid. Then it is deltoid which is taking care, which is most of it is taken care by the deltoid. So supraspinatus is this one which is moving in gear 1 or stage 1, assisted by deltoid. Then it is deltoid which is taking care. And then after that, deltoid is assisted by serratus anterior, the pushing punching muscle. And then after 180 degree, it is the rotations of the scapula which helps us to lean back, which is done by these fibers of the trapezius, the shoulder shrugging muscle, trapezius, upper and lower fibers of trapezius, which is doing it beyond this particular 180 degree by the movement of the scapula. So there are movement of this particular abduction which needs to learn or memorize in a detailed manner. Shoulder joint movement, which is having this wide range of movement, this abduction has got things to emphasize on. So this abduction initial part, supraspinatus, which is starting 0 to 15 degree assisted by deltoid. The supraspinatus is the thing which is helping out. Then after that, which is deltoid, and assisted with the deltoid is serratus anterior till 180 degree, which is 180 degree up to that serratus anterior is helping deltoid with serratus anterior, and beyond that this additional muscle which is coming, which is known as trapezius. Trapezius have fibers coming above and below. So we call them superior and inferior fibers of the trapezius, which are assisting this final 180 degree and beyond movements. So these are the 3 stage of this particular abduction. Abduction movement of the shoulder joint itself is a short note. So what you are going to write this particular abduction movement? So whenever this abduction is given, you have to describe it. What is abduction? Which is the lateral movement of away from the body, which is the shoulder joint is taking. So this particular shoulder joint movement has got 3 phases, we can say that: initiation phase, middle phase and final phase. Like first phase is assisted by supraspinatus, initiated by and assisted by deltoid. Then deltoid, which is taking maximum load, assisted along with it is the serratus anterior, the pushing punching muscle, and then 180 beyond that thing, which is trapezius along with the deltoid, which are helping these things out. And this is flexion, extension, abduction and adduction, medial rotation and lateral rotation. Be it what type of movement it is, you can place deltoid in it, except one thing, which is abduction. Deltoid can do anything, but no abduction. That's the simple rule. So this particular muscle movement is taking place over here, is assisted by the nerves. Like whatever the muscles are there, they are supplied by the nerves. They are doing this particular thing, like axillary nerve or other nerves, which is subscapular, upper subscapular, lower subscapular, whatever the muscles are they are supplied with, they are making this particular movement. This particular shoulder joint is innervated by this axillary nerve, which is taking this propulsion and joint position sense in this particular joints over there, this way. So these are the things that we related to this particular shoulder joint that we have to keep in mind. Now coming to the clinical problem that we have started. So this particular clinical problem, we start with this particular clinical problem, we call them as bursitis. So we learn about the bursa, and now we are going to talk about the diseases of bursa. That means the inflammation or disease of the bursa, we call them as bursitis. Itis, if you are adding, it is knowing to say that inflammation. So bursitis, this bursitis which is related to the subacromial bursa, we call them as subacromial bursitis. Now what happens? About, but what do you mean by the bursitis? That means this cushion is there, and if this cushion is also irritated too much with these movements, it may be inflamed. That inflammation we call them as bursitis. So, inflammation, if it is having over this region, what is going to happen? The patient is going to experience some pain, some tenderness, or some kind of pain, tenderness during the movement, right. So, this is what, or if it is too much, you may have a fever or feverish tendency like that. So, pain, tenderness over the shoulder region related to this particular excessive movement that can lead to this particular subacromial bursitis. Now, where this particular bursa is placed? Outside the capsule, outside the joint capsule. So, if this particular bursitis is there, see that this particular tendon is there on the floor. What tendon is there? Supraspinatus tendon, and above is there, which is having bone, we call them as acromial process. In between them, this particular blue one is there, there is bursa, which is subacromial bursa. Now, for example, this particular person, say for example a tennis player, is doing overhead smash again and again, and what they are doing? They are using the rotator cuff muscle. What rotator cuff muscle is made of? Supraspinatus, infraspinatus, teres minor, subscapularis. Out of these overhead smashes, if you are doing, out of these four, which one is more under this particular bony thread? Supraspinatus. So, which is right away under this particular acromion. So, this particular supraspinatus tendon, if you are doing this particular overhead smash again and again, this thing is getting a friction on this particular bursa, and this bursa is pressed on this particular bone, which is acromial bone. So, this particular tendon along with this particular bursa is getting irritated by this continuous friction, and this particular bursa becomes inflamed. Then we call them as bursitis. Now, if you are getting pain, like say for example 500 overhead smashes you have done, and then you feel like, oh, it's sore, then you take rest if you are taking it. Now, you say, now no, I have to practice more. Again you are doing something more. That means that inflammation, you are not letting it settle. You are not getting this particular body to recover from the illness. That is what the problem starts. So, this particular thing started with the bursitis, and remember this, it is lying on top of what? Capsule. What capsule? Shoulder joint capsule, and on top of this particular rotator cuff. So, this particular bursa may burst open, or maybe just like too much of friction may have a end which is friction, too much of friction leading to this particular bursal capsule or margins of it may fused with this particular synovial joint capsule or joint capsule, or maybe just like getting adherent to this particular tendons. Or for example, if you have this particular thing going on, the supraspinatus tendon may have a tear, and that particular tear is not healing well, may have a calcification. Further to it, adding to some problems with it. So, then we have this number of problems which is coming to it. So, this particular problem that we have started with, we call them as rotator cuff injury. That started with the bursitis, we did not stop, we did not take rest. So, next thing or next step of the bursitis is that this particular bursa is blended with this particular rotator cuff, and that particular inflammation is spreading from that bursa capsule to this rotator capsule. So, then we call them as rotator cuff injuries, which is repeated use of rotator muscles with this particular thing impinging on this particular coracoacromial arch which is above and producing an irritation. So, this particular rotator cuff, that means there is a muscular cuff which is made of supraspinatus, infraspinatus, teres minor and subscapularis, that too along with the bursa is inflamed, and that thing we call them as rotator cuff injuries. Now, you are taking rest of that rotator cuff, you are diagnosed with the neck pain over there every time you do an exercise or every time you do this particular problem, is hitting there. You are advised to take rest, but you are still not taking rest, you are still continuing. Then the next time happens there, this particular rotator cuff may have a calcification on the injured part. We call them as calcifications of the rotator cuff or calcified supraspinatus tendon. So, there may be a piece of calcium may be present on this particular region, and again you can imagine that if you have a calcium present in here over these calcium deposits present between this tendon and this bone, that is adding up more pressure and more threat. So, this particular condition we call them as calcified supraspinatus tendinitis, that means rotator cuff tendinitis which is calcified, which is leads to bursitis or bursitis leads to this. Then what happens? whenever the person is trying to move away this shoulder, this particular calcium which is present deposits impinging on this particular acromial process, and the patient is experiencing the pain, more it spreads it away and it cannot do it anymore. So, there is a range of movement restriction happens which is happening between 50 degree to 130 degree abduction. So, when an arm is by the side, there is no movement there, no problem. The moment it starts to stay away, this particular calcium or this tendon impinging on this, when it reaches to the 50 to 130 degree, that particular range, it is impinging and it is paining. So, this particular condition we call them as painful arc between this 50 to 130 degree, which is a sequel of this bursitis or calcified supraspinatus tendinitis. Again, despite that the person is doing this repeated examination, then what happens? The bursa and this particular joint capsule and the rotator cuff fuses together and become adherent. That the last stage we call them as adhesive capsulitis. That means capsule is frozen, cannot move anything beyond that. So, this is the last stage of shoulder joint problem. So, started with the bursitis, then it moved to this tendonitis, then tendonitis is moving to the calcification, and then it is moving to everything fused together and together it is lost. So, we call them as adhesive capsulitis of the glenohumeral joint. So, it's the stages of it. So, how you can be tested on it? They are going to ask about diseases? No. They are going to ask about this particular thing which is known as the rotator cuff. They are going to ask about the bursa with the clinical problems. So, this clinical problem they will be giving to you as a person is coming to your clinic with a shoulder joint problem like this. Whenever this person is trying to move this hand away, after some time it is paining and it is paining and paining up to 30 degree like that. So, they are giving a clinical problem. Unless until you understand why this particular range of movement happens to start at 50 degree to 130 degree, you do not understand how these things are clinically relevant. Understand? So, for that reason I have to tell you about all these things, diseases or diagnosis of disease. You are not supposed to know about this particular diagnosis, but you have to understand how this particular clinical problem is coming to you. If you do not understand why this thing is coming between the range of movement 50 to 130 degree, not at rest, you cannot decode the problem. So, you have to know the diseases, what is happening there, and that is happening because of this tendon injury which is having there. What tendon is a rotator cuff tendon? Out of the rotator cuff, which is more vulnerable is supraspinatus. So, supraspinatus tendinitis or rotator cuff tendinitis or the capsulitis or this particular bursitis. Which bursa? Subacromial bursa. Clear? So, clinical problem will be coming into in this way. This is one aspect of the clinical problem. Other problem which is related to the shoulder joint, this is one of the commonest problem, we call them as shoulder joint dislocation. As this particular shoulder joint is highly mobile, the mobility is leading this joint to very unstable, and this particular shoulder joint may come out of the glenoid cavity. Then we call them as shoulder joint dislocation. There are two ways shoulder joint dislocate, anteriorly or posteriorly. So, we call them as dislocation of the shoulder joint, anterior dislocation, posterior dislocation. This anterior dislocation is also known as inferior dislocation. Why it is inferior dislocation? Once it comes out, this moves under to this particular glenoid cavity. That is why you call them as inferior dislocation. So, this dislocation of the shoulder joint means it is getting out of what? The glenoid cavity. Then what happens? This goes under the scapula and then moves up in front. Bediye chole eshe, it moves out and moves forward because of the pull of this big muscle which is pec major. So, pec major pulls it anteriorly. So, this shoulder joint or this bone gets down and then moves anterior, just like under the clavicle it becomes popped up. So, this particular thing we call them as dislocation of shoulder joint, anterior or inferior is the same, because they are basically inferiorly going out then moving anteriorly. That is why you call them as anterior, also known as inferior. Now, if they are coming out over here, a nerve which is present over here is damaged here is axillary nerve, which is running on this particular scapula as the neck of the scapula. So, this particular head of this particular humerus may cram this nerve under to it if this person is making a movement after that. So, shoulder joint to khule geche, chole esche samne, se tobu hath nere jacche, edike dhoracche, odike ghoracche. So, this movement, weird movement, is adding up to this particular cramming of these nerves. Which nerve? Axillary nerve. So, what is the question out here? Are they going to ask about this particular shoulder joint dislocation? No, they are not going to ask about shoulder joint dislocation. They will tell about there is a shoulder joint dislocation and what is trouble out of shoulder joint dislocation. What anatomical factor or what anatomical structure will be at trouble if you have this anterior dislocation of shoulder? What anatomical factors will be at problem if you have shoulder joint dislocation? Axillary nerve. So, they are going to talk about the axillary nerve. So, that thing they are going to ask. They are not going to emphasize on shoulder joint dislocation, how you are going to reduce that, why it is happening there. They may ask about other thing, why this particular shoulder joint inferiorly going and moving anteriorly. If it is going inferiorly, inferior dislocation, why this particular thing is coming anteriorly? Because of the pull of the muscle, they are pulling it, because they are moved, they are saying pull of this big muscle. What big muscle we have anteriorly? Pec major, that is pulling it out. So, that is why it is moving anteriorly, correct. So, this nerve injury, that is important for us. The movement, that is important for us. That is going to be tested, not this particular whole things which is there. Now, why do this particular joint dislocate? They may ask about it. So, why this particular joint is prone to have dislocation? What are you going to say? So, explain why shoulder joint dislocation is common. How are we going to tell about it? Someone pulls very hard, okay, but if somebody pulls my leg, it is not dislocating. So, you figure out why the shoulder joint dislocation is common, right, from book. So, why the shoulder joint dislocation is common, explain why. 4-mark question, and write it, write the question. Why shoulder joint dislocation is common, explain why. 4-mark question, you write it, okay, that is your work you are going to do. Okay, write it. That is what I want you to write it, right? That is why I want you to go through the books. So, dislocation of shoulder joint is common, explain why, right or wrong, and write it, every one of you. This will be your exam question. No, I am kidding, but it might be. Okay? Coming to the other problem related to the shoulder joint. Now, this tip of the shoulder, you know, this part we call them as tip of the shoulder. Now, this tip of the shoulder is having a nerve supply from C3, C4, C5, that means cervical spinal nerve, we call them as C. So, C cervical spinal nerve, 8 pairs of the nerves are there. We number it 1, 2, 3, 4, 5. So, this region tip of the shoulder is supplied by the nerve which is C4 domain or C4 spinal nerves. So, tip of the shoulder which is this region is dermatomically or spinal nerve supplies over here, we call them as the C3, C4 domain or C4 predominantly supplies this region, we call them as a region supplied. So, if you have any problem on this region, we call them as diaphragm or under diaphragm, any problem can refer to the tip of the shoulders, T4 domain, C4 domain. So, this is a kind of shoulder tip pain. You will understand this when you study this abdomen, but I am just introducing this word about shoulder tip pain, and this dermatome or this nerve supply of this region is skin supply, of course, is coming from the spinal nerve which is coming from C4, that means cervical 4th spinal nerve, and 4th spinal nerve is known as supraclavicular nerve. Okay, this is one we have to know, and the rest thing will be covered in abdomen. Frozen shoulder, this is another enmity, that means shoulder is frozen, cannot move. We do not have any clear reason why this particular shoulder is frozen. That means shoulder movement is kind of like a damaged, cannot do it properly. Free movement is shoulder is not there, cannot bend it, cannot lift it like that. Appears to be because of this particular problem with the capsule, appears to be problem with this bursa, or appears to be problem of this particular tendon, supraspinatus tendon, or maybe combining everything. So, together may add up, or maybe having just like a pain in the shoulder because of the infection, which may add up to this particular problem which we call them as shoulder joint. frozen or frozen shoulder, which is a common clinical problem beyond 50 years of age. And this particular problem, having this particular capsular ligament and the synovial membrane or synovial fluid may be just like a dried up as well. So, there may be a varied reason for the frozen shoulder thing, which may be because of this pain, stiffness and movement error may be there. But this is different from that of rotator cuff injury. Rotator cuff injury is a structural injury which can be comprehended. Ultrasound, MRI, you can pick up a problem, calcifications on it, like or this particular problem is there. But the rotator cuff injuries is not our problem to understand, decode. What we have to understand and decode is bursa and this one and this rotator cuff, how these things are formed, where exactly they are present, what are the structural contributions of these particular tendons to this rotator cuff, and which out of these 4 tendons are more prone to injuries and why so. And once this particular supraspinatus is damaged, it takes a lot of time to recover because it is relatively avascular. That means blood vessel is less. So, recovery is very slow. There are no other chance of quick recovery than taking rest and giving rest to it. Stop doing this repeated movement, what creates this particular problem out there. And if it is out of hand, you have to go for surgery. If it is completely tear, then we have to suture. Many times you have seen that, like cricket players, they have the shoulder point injuries. The racket players, the tennis players, they have these injuries. This supraspinatus tendon may get ripped. So, you have to stitch it and do rehab, recover and come back, right. This is a very common clinical problem or sports clinical problem. So, altogether this is about this particular shoulder joint and related things. Shoulder joint, everything you have to know about, movements and this particular joint architecture, clinical problem, you understand this. But again, this is not what is expected of you to learn. What is expected is about anatomy of this particular rotator cuff and what makes these things. You have to understand this disease of rotator cuff, but not emphasizing it. Rather, you have to emphasize on architecture. You have to emphasize why this particular shoulder joint is prone to have dislocations, rather than how to fix this dislocation. And if you have dislocation, what threat we have, like that, right? So, this is all about it.